Live from the Bay State Medical Center Residency Conference for Emergency Medicine. I am Dr. Zachary Testo.
And I'm Rachel Gershaw.
And we are here to have our first wellness debate. The topic du jour is going to be centered around physician burnout and specifically the diagnosis of physician burnout. Basically, we're talking about should there be the creation of a diagnosis in the ICD-11 or the ICD-12, which is centered around physician or clinician burnout? Should that be something that we as providers can potentially get diagnosed with in the future? Now, I should make it known that the ICD-10 and 11 have a syndrome known as burnout, and people have the ability to get diagnosed with burnout. However, this is a underutilized or basically non-utilized diagnosis. I would also like to point out the definition of burnout is a syndrome centered around problems related to employment or unemployment and feelings of energy depletion or exhaustion, increased mental distance or feelings of negativism or cynicism related to one's job, and reduced professional efficacy. Now, when we talk about the three burnout domains, those are basically what we're talking about. So it's not too far off from what we are talking about all the time and diagnosing ourselves with. Should this be something that a psychiatrist could potentially come in and diagnose us with, as far as could this be a mental health disorder?
So during the next few minutes, Zach and I are going to have a little fun debate. So I'm going to be the position against this topic, and he's going to be for it. So he's going to be for having the diagnosis in the ICD-11 or 12 as our individual illness, and I'm going to be against that. Listen, take notes if you need to, and make up your own opinion. We'll be sending out a survey at the end of this to see where you guys lie.
Okay, so let's get started. First off, Rachel, how many physicians are there in the United States right around now? The answer is around 960,000 people. The amount of people that play fantasy football is around 56 million people, and they cost the workforce around $16 billion a year, according to some estimates. The 960,000 physicians alone, which is 1/56th of that amount of people playing fantasy football, they are costing close to $5 billion a year worth of losses because of the effects of burnout. This is not an insignificant number, and it's something that needs to change on the short term. We can wait as long as we want, but really this is a disease that is affecting our patients, which I'm going to continue to frame this entire thing as this is going to be good for our patients.
First of all, I like that you're distracting us with big fancy numbers that cost a lot of money, because that's, really helpful towards your argument. But I'm going to shift away from that and just say that you keep focusing this on the individual, but this is an occupational systemic issue. This has nothing to do with the individual. This is the place that we've been put into because of our own circumstances. So you should not be putting this on us and throwing money into the equation. You can't just put a number on each physician's life and each physician's mental health. That's not fair. A doctor is working, a doctor is feeling burned out, but it's not our fault. It's not the physician's fault. It's the system's fault. They've put us in this place. They've created this workplace where we cannot get our work done. We feel stressed. We feel overworked. We just shift this paradigm to put it on the occupational exposure on the workplace. And now you're trying to shift it back, saying that it's an individual thing that is our fault. And it's not our fault. It's the fault of the place that we've been put into and the system around us that's been built and is not supporting us well enough.
So you're saying that instead of a person getting diagnosed with this disease, that we should be diagnosing a healthcare system?
Yes.
What good is that going to do in the short term for the people who are suffering right now?
Well, we can automatically put programs in place that help the environment, that help the whole health system to fix this, so it doesn't get down and trickle down to the individual physician. So it's not individual workers that are feeling it. So we can have immediate programs in place for the whole institution, for the whole department, that prevents essentially us even getting to this point and having to be diagnosed with burnout on an individual level.
As we know throughout our research, burnout has been linked as a precursor to PTSD, depression, suicidality, substance abuse, all of which we aggressively try to treat. And we have specific programs like physician health services created out there to help people with these things. Why wouldn't we want to identify a disease early on that somebody can carry with them as a diagnosis in order to get honed in treatment from mental health professionals with a specific treatment plan like cognitive behavioral therapy, things that have been proven to work for syndromes like this? I think that the people in need of it right now might benefit from having a diagnosis associated with them so we can start to target high risk people and focus efforts where it really needs to be.
So first of all, I think it's kind of unfair that you're putting burnout in the same context as chlamydia, where it's stuck in your chart. And essentially, you have this diagnosis that's stuck in your medical chart forever. It's one treatable thing, and then it's gone. We don't want burnout to be the same thing, because every time you open up a patient's chart and you see chlamydia, you're automatically kind of have a bias towards them that, oh, they must have done something wrong to get that. And again, this is the system. It's not the individual's fault. So if we're putting the stigma right into their medical chart, every time you open up, you're going to see, oh, look, they were burned out, and might have some negative connotation and some stigma towards that definition.
All right. Can you tell me a little bit more about the stigma associated with this?
Yeah, so I think that the problem is that it's a little bit of a slippery slope. So some employers and some medical boards might see this as part of a mental illness, and that might actually prevent you from getting hired down the road. They might look into your medical conditions and put it in the same category as some other things and might not see that you're fit for duty. And I'm not saying that I agree with this, but I certainly don't want that to weigh in on someone's decision to hire you or feel like you're medically fit for the job, again, because the system's failing you.
The safe harbor legislation is intentionally designed to be able to protect physicians who are following the rules, who are going about doing things. And if they were to lie on a medical application that they have a mental illness and they say they're not getting treated, this is deviating from the rules. This is no longer putting you in that safe harbor legislation umbrella to be able to say that you are following the guidelines, and then you yourself are knowingly putting your patients at risk. That's what society has deemed is the right thing. That's why they're asking these questions on board questionnaires for one particular reason, among others, which is liability, I'm sure. But one of them is in the interest of the patient, and patients were neglected and taken advantage of before these protections were put in place. What do you have to say about the board people who are asking the question about mental health still right now?
This is going to be something that you have to write an explanation that you were going through this, when really it's just a transient moment in time where for a couple weeks you may have felt a little bit of burnout because you didn't have the supports in your hospital. And now your medical board is going to look at that and see it as a potential weakness that you weren't able to deal with a few weeks and spin it around on you. You weren't able to deal with a couple weeks of pressures from the hospital that was a little bit outside of your realm. And that's going to be a red flag for them that you can't handle increased pressures on the job. So I'm just a little bit worried. And again, that the medical board is going to look at this and is going to say that they're not fit for duty. And this could essentially become a disability. Who knows where that could lead us? I just recently heard a story about a physician who during COVID time, they took away her nurse, they took away her secretary. She was doing everything herself. And the system wasn't supporting her. And where did that leave her? She's taking a 2-month leave of absence right now from something she loves doing because of all the pressures that the system put on her. And I just don't want to see people getting to that point where they're essentially forced to completely stop working and doing something they love because of the pressures that the system are putting on them. Some of the things that I'm looking for in terms of change in the environment are to improve workflow efficiency, to increase teamwork, to have better leadership so that it doesn't lead us down the path to burnout in the first place. What sort of things are you looking at implementing on the individual level to help with physicians and burnout?
We are constantly trying to promote behavioral health protections for physicians and to encourage people to seek the resources that are established. In Europe, they made the diagnosis of burnout, and it's been seen to at least partially start to destigmatize the conception around it. We have medical students who haven't even worked a day in their lives who are already thinking about how they would lie to their employers or keep a mental health illness close to their vest and not disclose it to anybody, or perhaps not seek treatment because they were afraid that it could potentially get disclosed, even though they know in their hearts that their medical information is likely to be preserved and protected, they're still worried about the repercussions years down the road. We want to have actionable change right now. And I think it starts with being able to open up the doors to people who don't want to formally be diagnosed with adjustment disorder or depression or PTSD, but might need to be protected with a diagnosis of clinician burnout in the short term. You can say you're just taking a mental health day, but perhaps that's not going to be enough to get somebody out of a cycle that could potentially end up with the severe effects that we see with suicidality and substance abuse.
So essentially you're talking, but all I'm hearing is system, system, system. So you're talking about how in medical school already people are feeling burnout. I mean, how can you say that that's not a systems issue, that something is wrong that far down the line?
Ideally, we would have opt-out mental health. I think what we would need for people entering this job force early on in their medical training is opt-out behavioral health, where starting on day one, when they're getting their short coat, they are being exposed to talking about their feelings, talking about their successes, and more importantly, talking about their failures. As they continue to get exposed to all the systemic issues that you're referencing, they have an outlet for this kind of thing. And then we know where people are at on the spectrum. If it really is a continuum where you start at burnout and you start to slowly move towards depression and everything, we need to be able to have a barometer. And what better way to be able to measure that kind of thing than a formalized diagnosis that we can track epidemiologically in order to help us make changes right now. During a pandemic, you want to know the numbers, even though you're only treating the individual in front of you. And this is no different. We have an epidemic of burnout going on. We want to know the numbers right now.
All right. So another thing I want to bring up is the gender disparity in this. About 50% of women report that they have some sort of mental health illness or meet criteria for this. And only about 6% of them actually report it to the state on their medical licensing. I mean, tell me how that's not an issue and how that's not a problem with the system, that women are scared to A, admit that they have it in the first place, and B, to seek help and treatment and tell people about these things.
I agree that treatment reluctance is going to be the biggest hurdle and the biggest barrier here. The reason why I'm saying it should be a diagnosis is to start to normalize the experience of being a person with burnout that's seeking treatment and trying to get themselves better for this. What I don't want is, ads 10 years from now of, has you or someone you love been affected by medical burnout? And then we've got all these repercussions later on that we didn't think about in the moment because we were under treating or not treating a preventable illness within our own population right now.
So I'm just trying to figure out what happens. So if a physician comes into you in the emergency department and says that they're burned out, where are we sending this person? I mean, our mental health workers are already at capacity. They can barely handle what we give to them now. Where are these people going to seek treatment?
Ideally, all institutions, and ours is no exception, has an employee assistance program. People set aside as mental health counselors who are specifically there for the use of the employees within an institution. We know at Bay State, just like at all other major institutions, that it is a tough environment. And you're right, systemic issues are constantly causing pressures on us that were never anticipated, and you can never really intimate to somebody else. An employee assistance program will be the first place for these people to go.
I'm just worried that down the line, if something shows up on my insurance that says that I seek treatment for burnout, that employers might see that as a red flag, that pre-existing conditions, if they're allowed to be involved in insurance ability to deny your claims. I mean, how are we going to deal with that? Just because I had a few weeks of burnout, again, that was a systemic problem that my institution put on me. It's going to prevent me from getting the help that I need.
I don't have a retort for that. I think you're bringing up an excellent point of we can't control the retaliation or the protections that other employers might have on them. And it is something definitely to consider in this argument. So Rachel, in a perfect world, and let's say we fixed all of those systemic issues that you're talking about, we're still in a business of death, dying, and suffering, which takes an emotional toll. And we're never, ever going to be able to alleviate that portion of it. If we do everything we can to fix the system, we still have people with burnout. What are they going to be looking for as far as support if they're not going to be formally diagnosed with something?
We go back to building resilience, and that's the biggest thing that we have to do to try to combat this down the road. So that's again, something that the system has to have available for you. How are you going to build your own personal resistance? How can you execute that after a tough case or a tough day at work? Do you have huddles, things to support you, debriefs, and things like that right in the moment? And that's, again, system-based things that can be put in place. But I think building resilience from the ground up is really what's going to help this in the long run.
So in my perfect world, if we did have a diagnosis of it, we could have a system such as like we have with FMLA right now, where people can take medical leave of absence because of something that is detrimental to their own being and, more importantly, detrimental to their patients. And they can file for something, get a formal diagnosis that would be protected under insurance, and then hopefully be able to remedy that in the short term, rather than carrying these things under the surface and having them coalesce into something bigger, potentially more life-threatening or life-altering, like the things that I've been harping on the entire time. So for my closing statement, in conclusion, the syndrome of burnout, and specifically clinician burnout, is characterized by when there is a mismatch between the work that needs to be done and the work that can be provided. In the short term, I see no clear magic bullet to be able to say that the work that needs to be done will be outmatched by the work that can be done by our clinicians. And in the short term, I'd like to see supports put in place as far as mental health, one of those being a formal diagnosis so that we can give people the acute care that they need in an effort to prevent further repercussions. That's the world that I want to be able to see, and that's the stance that I'm taking with regards to clinician burnout being a formal ICD-11 diagnosis.
So I think from what we've been discussing over the past few minutes, the most important thing to fix right now is to fix the workplace, to fix the environment that we're all in, and to take all of the stress and the stigma off of the individual, to not make an individual diagnosis for burnout, because this is going to add increased complexities in the mental health workforce. It's going to potentially compromise your job down the road. And your medical licensure and boards. And until I have and feel that I have 100% protection from all of these areas, I do not want to get diagnosed with a individual diagnosis of burnout. Burnout is like a bad relationship. It's not me, it's you. And I don't want you to blame me for your system failures. But
It's never easy hearing that. So thank you for watching our debate about the diagnosis of clinician burnout. What we'd like is for your opinion on any and all matters related to wellness. If this is on YouTube, please feel free to comment below. If there is feedback that you can give us during the conference day, we greatly appreciate it. As always, try to keep your temperatures low
and your spirits high. And if you do feel like you're having any issues with burnout, please come talk to one of us or talk to one of our program directors. We're all here to help you.
Thank you, everybody. Have a great day.